Hello, everyone, and welcome to today's webinar hosted by the Canadian Frailty Network. The title of today's talk is Anticipatory Long-Term Care Electronic Resident Triage Tool, or ALERT, for Canadian long-term care homes. The investigators are Michelle Grinman at the University of Calgary and Greta Cummings from the University of Alberta. Before I formally introduce our speaker today, I just want to go through some housekeeping slides. My name is Perry Kim, Assistant Director at the CFN, or Canadian Frailty Network. At the end of the webinar, you'll have a chance to post questions on the side panel where you'll see, I think about fourth way down, you'll see questions. Please type in your questions and we'll try to get to as many as we can in the remaining time after the speaker is finished. As another reminder, after the webinar has been completed, a questionnaire or survey will pop up, and please spend a few minutes to complete that questionnaire. It really does help us in terms of any feedback you may provide us to make the webinars more interesting and interactive. The webinar today's webinar will be posted on CFN's website 1 or 2 days after completion today. As a reminder, we have 2 webinars scheduled for September 12th and November 21st, so please visit our website for more information on these 2 webinars. And lastly, as a reminder, if you haven't already done so, please register for CFN's National Conference, which will be held September 20th and 21st in Toronto. And we also have an innovation showcase that will showcase innovations from across Canada. We have quite a few interesting innovations to showcase this year. So without further ado, the presenter today will be Michelle Grinman. She's a clinical assistant professor in the section of general internal medicine at the University of Calgary. She's a general internal medicine specialist with Alberta Health Services and medical lead for the seniors palliative and continuing care portfolio in the Calgary zone for the Complex Care Hub program. Without further ado, Michelle.
Thank you. I'm just going to share my screen here. Can you see my screen?
Yes, we can.
And I just need to switch it, right? Here we go.
Yes.
Is that better?
That's great.
Okay, so thank you very much. So I am, as we mentioned, a general internist, but became interested in long-term care, particularly emerge visits, because I see these patients as an internist in the hospital, and so started doing this work when I used to live in Toronto, and then have recently, in the last 3 years, moved to Calgary, but continued this project as I moved to Calgary. So as we mentioned, the name of our study is ALERT, or the Anticipatory Long-Term Care Resident Triage Tool. And we performed a pilot intervention study in 4 Canadian long-term care homes to test out the e-Interact tools that were established in the United States. And my partner, Greta Cummings, was unable to attend today, so I'm presenting on behalf of both of us. We have no conflicts of interest. We were funded by the CFN in 2015. Our objectives today, so we want to talk a little bit about the importance of proactive identification of residents at risk of health status decline in long-term care, also an introduction to the e-Interact tools and how they're designed and their purpose, as well as the lessons learned from implementing the e-Interact tools in 4 Canadian long-term care homes over the past couple of years. So first of all, just kind of a bird's eye view at the healthcare system. 1 in 3 seniors who live in long-term care visit the eMERGE. This is from CIHI, looking at potentially avoidable hospitalizations from long-term care. It was estimated that almost a quarter of those were for potentially preventable conditions, most commonly pneumonia and urinary tract infections. And 10% of these visits were actually for less or non-urgent. So a quarter of these were because of falls, but there were also some other non-urgent reasons for coming to long-term care. The range of cost of a standard hospital stay in the country is between $4,000 and $11,000, and I would say that a frail senior who comes to the Emerge has been shown to be more expensive. They tend to stay longer, they have a longer length of stay, and even just an Emerge visit is almost 2 to 3 times more than for a younger person with less comorbidities. At the time when I was living in Ontario, we were in a period of what, the Drummond report came out, and there was a period of looking at austerity measures in the healthcare system, and we started looking at how to reduce potentially avoidable hospitalizations. Since then, Choosing Wisely has actually come out with a statement and some sort of guidance around what to do with long-term care patients. And so their message is, don't send frail residents of a nursing home to the hospital unless their urgent comfort and medical needs cannot be met in their care home. And the reason for that is that, as you might imagine, residents who are in long-term care and then get sent to Emerge spend long periods in an unfamiliar and a very stressful environment in hospital. And if you're already frail, or if you already have a little bit of dementia, that can be quite scary and can be detrimental to vulnerable seniors. And indeed, when you look at the literature, in terms of comparing hospitalization for older adults or keeping them within their place of residence, whether it's long-term care in the community, what we find in the literature is that transfers to hospital for assessment and treatment of a change in condition are actually of uncertain benefit. So we often think that if they go to the hospital, they'll see a specialist, they'll get all these tests, and that they're probably safer there. But for vulnerable seniors, we're starting to see in the literature a trend towards increased morbidity and mortality. And the morbidity comes from, as you can imagine, that they're in an unfamiliar environment, which sets them up for delirium. And in the long run, after the hospitalization, some of them end up having cognitive changes. They're also more exposed to hospital-acquired infections, side effects of their medications. If you've ever been admitted to the hospital, you know that we don't let people sleep in the hospital very well. There's noises, there's noisy neighbors, there's labs that are done at 5 in the morning. And so people tend not to sleep, which is a setup for delirium and cognitive decline. As well, seniors who are in hospital tend to have their meals brought to them. They're not mobilized as much, and so they rapidly lose muscle strength when they're bedridden, which sets them up for increasing falls and more likely actually to be admitted to long-term care at a year if they're not already. There's also an increased risk of death within 3 months of being hospitalized for long-term care residents. So although some changes may be unexpected, a lot of times in long-term care, some of them can be predicted. And from our experience, as well as from Choosing Wisely, when you look at Canadian studies and US studies, somewhere between 40 and 47% are potentially avoidable. What Choosing Wisely suggests is that in-house care is more likely to provide individualized care with better comfort and end-of-life care for patients or residents who are living in long-term care. And it's important to establish a clear understanding of patients' goals and wishes, taking into account their current health status, values, and preferences to reduce the likelihood of an inappropriate transfer. And this was something that we were really aiming with this study, but Choosing Wisely kind of emphasizes it, is that goals should be discussed earlier and more often with patients and families. One of the important sort of clinical pieces to think about when you're thinking about residents in long-term care is that when they show a new symptom or when they have a change in status, that it's not just an incidental finding, but that often it's actually a sign that they're changing, that their condition is changing, that their progression towards death is changing. So functional changes, if they're requiring more help, that's telling you that they have a higher symptom burden, that their disease may be progressing. If they're falling, this is suggesting that they're becoming weaker, and especially if they've had an injurious fall, such as a hip fracture. And oftentimes what we'll see is that people say, oh yeah, this person falls, but actually a fall is a suggestion that this person's becoming weaker and weaker. Delirium is a suggestion that the mind is being affected by something that's affecting the whole body, and that the mind is unable to overcome the comorbidities that this resident has. And again, if there's anything new or worsening symptoms, that's telling you that the body has changed. But what we find sometimes in long-term care is that while on a day-to-day basis the staff may be able to identify that, what we wanted is to be able to show the trend or the trajectory to try and be able to discuss goals of care more proactively. we looked, so in the interest of time, I'll only talk about the Interact tools, but we did look around to other programs and particularly hospital at home type of programs. So there is a program in the United States called the Interact or Interact 2 tools. This initially started as a quality improvement project to prevent ER transfers from long-term care to hospital in 25 nursing homes in 3 states in the United States. It was actually nurse practitioner-led education and tools for assessment, communication, and management. And they were able to show a 17% reduction in hospital admissions when comparing these 25 nursing homes to a comparator group of 11 nursing homes. And they were able to show a reduction in cost. Subsequently, they began to, so Dr. Auslander and his colleagues who developed the Interact tools joined forces with Point-Click Care, which is the largest vendor for electronic health records in North America for long-term care. They have about 70 to 80% of the market share, depending on where in Canada and the US. And they took the Interact tools and embedded them into the software to try and create a program that would have early identification or early warning signs, but as well have some tracking and process improvement and quality improvement tools. In the United States, they found an 18% or more reduction, depending on the centers, in preventable hospital admissions and readmissions, as well as ED visits. And they found that the long-term care homes that used the Interact QI program that was embedded into Point-Click Care were able to leverage decision support tools, care pathways, as well as a hospitalization tracking tool. And so in the United States, they found that this translated to less time documenting, better compliance with standards of care or with legislation that they have in the United States, as well as better patient outcomes. And this is just an example of some of the care pathways. So it's quite well established. You know, they have a care pathway for shortness of breath, for change in behavior, for dehydration, and all sorts of other examples. And this was not meant really for you to memorize it or to even wade through it, but just to see the clinical reasoning that has gone into the Interact tools. So these tools have never been officially tested in Canada. And that was the reason for assembling the ALERT research team. Our research team has researchers and clinicians from 4 universities. So I'm at the University of Calgary, and there are a few others at the University of Calgary as well. Greta is at the University of Alberta. And then we also have some researchers from New York University and University of Toronto. And we've gotten research ethics approval from the University of Calgary and Alberta, where the PIs are currently located. We've worked with 2 long-term care organizations. The one in Ontario, we implemented in 3 long-term care homes within the organization. And then in Calgary, we used one of the long-term care homes as well. And then we also partnered with Point-Click Care. The objectives of our study when we started, and you'll see why I'm saying when we started, were to test and adapt the e-Interact tools for use in Canadian long-term care homes, and then to determine whether the e-Interact tools reduce potentially avoidable hospitalizations, improve resident and family satisfaction, improve communication among staff and residents or their families. And then we were hoping as well to add a triage component, because the e-Interact tools currently don't have a component that sort of predicts the trajectory of a resident. For example, are they entering the last 3 months of their life, which tends to go hand in hand with changing the care plan and adjusting the goals of care. Clinically, what we were anticipating that this would bring about benefits in the long-term care homes was that the team would be more likely to collaborate to identify residents at risk of decline, either steadily or suddenly, to identify them early, and then so that those residents would get additional assessments, management, and be supported to stay in-house. We also felt that this would provide an opportunity to deliver optimal care, including the transition to end of life. So I'll just go through what the process is for the frontline staff in terms of using these tools. So this is the stop and watch tool that was initially developed by the Interact 2 for Interact 2. So this is what was a paper tool that they have then put into point-click care. And if you look at the wording of the tool, this is meant for healthcare aides to fill out when they're with a patient. And the reason for this is that healthcare aides tend to be the ones that have the most contact with patients and know them the best. And so giving them an opportunity to express when they notice that something is different is thought to be enabling them to voice their opinion or to voice their observations, but also potentially to pick up patients that may not have been identified previously. And if you look at the language, it's actually not as medical, but rather more general, so that it can cast a wide net and catch residents that might be at risk. So seems different than usual, talks or communicates less, overall needs more help, for example. So the healthcare aides are meant to fill this out. And then this is meant to pop up in the nurses alert section in point-click care. This is the process that we ask the healthcare aides to follow. So if they notice a change in a resident's status, they decide, is this something that is urgent that I need the nurse to come and see now, or is this something that can wait? If it can wait, then they fill out the stop and watch tool and the nurse sees it when they check their alerts. They're supposed to be checking twice a day. If it's urgent, then they notify the nurse and then later fill out the stop and watch tool. And then the nurse assesses urgently. So for the healthcare aides, it was a fairly simple process that we asked them to follow. The nurse has a slightly more complex process. So this is for urgent alerts. The nurse is meant to check alerts in point-click care twice per shift and also respond when the frontline staff come to talk to them about a change in condition. The nurse is then meant to fill out a change in condition form, which is a long form, system by system. And so they click their way through and, do they have abdominal pain? What are their vitals? And then depending on the urgency, the nurse would call the physician, discuss it with the physician, and then they would decide on a plan of action and whether or not to notify the substitute decision maker. The nurse is meant to document the orders that the physician gives her over the phone, and then the change in condition tool actually pre-populates an SBAR form. So for those of you that don't know what an SBAR form, this is a method of communication that nurses use that is situation, background assessment, and recommendations. And that's what they use to communicate with the physicians. So the tool is meant to help them print that out and have it so that they can use it to communicate with physicians. And then the nurse and the physician are meant to change the care plan, change the orders. If possible, they try to keep the resident in the long-term care home. And if not possible, then they transfer to the emerge. For non-urgent alerts, it's almost the same, except that the nurse doesn't call the physician urgently, but rather the physician sees the reports from the nurses when they come into the long-term care home, and then they decide on a plan of action and discuss with the substitute decision maker. So we've had a tumultuous journey, to say the least, in trying to implement this. Initially, when we began this project, we thought, well, this is a well-established tool in the United States. The culture is likely similar. And so we just need to adapt it a little bit and then we can validate it. Even the adaptation of the tool it took us 6 months. So we realized that we needed to add Canadian lab values. And this actually took 6 months to change in point-click care. It actually delayed us from starting. And then because whenever you change something in point-click care, you want to make sure that it doesn't change patient safety. We had to do tabletop exercises to ensure that none of these changes would in fact change the safety of the tool in terms of its use. So then when we finally did try to implement in Toronto, we did some engagement with the physicians, we did group education sessions for all the frontline staff, and then there was actually a team that mentored the frontline staff during the first few weeks of the launch, particularly the first week, but who were available to troubleshoot and help to mentor people in using the tools. In Toronto, we had several challenges. One is that after about a month and a half of implementation, our HQP changed jobs and went to a different organization, and so that resulted in we were not able to collect data and surveys. And then as we were trying to implement, we also had outbreaks that delayed our start. And then we had minimal uptake by the staff of the tools. But because we were in transition with the HQP, it was at the time we were having some difficulty understanding why they weren't uptaking the tools, because in the meantime we were hiring a research assistant to help us. In Toronto, we also had to stop the study. We had some protocol breaches, which resulted in us actually terminating the study early in Toronto. Subsequently, we shifted gears. We were already in discussions with a long-term care home in Calgary. We wanted to test it in 2 different places in Canada to see if there were changes in culture or if there was anything that was similar or different between the 2 different provinces. And so we then implemented in Calgary, used some of the same methods for implementation, but actually added more, which I'll get into a little bit later. And again, had similar challenges. So there were outbreaks that delayed our launch of the tool. And then this particular home also was under construction, and so they had to move all the residents from one side of the nursing home to another. And our REB modification happened over the summer. So there were lots of things that delayed us and made it a little bit challenging. And then what we found in Calgary is, while in Toronto the staff used the tool very infrequently, in Calgary they didn't use the tool at all, despite many more efforts for implementation and a lot more audit and feedback and hands-on training of the staff. So as I mentioned, the conversion to Canadian lab values, this is just a screenshot of what we ended up needing to do, is to give the staff a conversion table, because in order to make a change in point and click care, the Canadian lab values were put beside the American lab values, and this change actually happened in all the long-term care homes in North America, including the American ones. And so to give the frontline staff kind of an equivalency, we gave them these conversion cards. In terms of implementation strategies, so at both Toronto and Calgary sites, we identified clinical champions, we trained them, we did introduction sessions several times on the study itself, but also on the benefits of using these tools. And we did that for the champions, the administrative leadership, the frontline staff, and the physicians. We also put in updates in the physician newsletters, and we had sort of one-on-one coaching and mentoring for the frontline staff to support them in using the tool. In Calgary in particular, Point Click Care also made available some educational e-modules that are used in the United States for the frontline staff, and their partners from this organization named Pathways in the United States actually came to Calgary and trained our key champions and research team in how to implement and also how to train the frontline staff so that we would be in line with how they do it in the United States. We then had one-on-one education with the professional staff, and we offered them hotspot education to use the tool whenever to help them in using the tool. We also put many more reminders up in Calgary. We had emails, posters, stickers on all the computers. We had reminders in their day timers, reminders for the key champions, and we had audit and feedback where if we saw that there were some cases where there could have been an alert, we would go back and discuss it with them. In terms of the data that we collected, so as I mentioned, there were 3 sites in Toronto and there was 1 in Calgary. We reviewed 97 charts of 97 patients' charts in Toronto and 20 in Calgary. We had a much shorter implementation time in Calgary. We had a lot of pre-surveys in both sites. In Toronto, because of the loss of our HQP and our research assistant and some of the issues that we had in Toronto, we had a hard time getting the post-survey, so we only got 14, which was in one of the long-term care homes. In Toronto, we actually did do surveys of the residents and their families for those that had either had an alert or had gone to the emerge. In Calgary, we didn't do that because there were no alerts. And sorry, the surveys were for people who had alerts in Toronto, and in Calgary there were no alerts, and so we didn't do that. In Calgary, we decided that instead of the survey that we would actually do focus groups, because we really wanted to understand why they didn't use the tool and to get suggestions for the future. And so I'll go through that in a little bit. So our chart review, this was the most extensive part of our data collection. We chose residents who had had either an eInteract alert during the time that we were collecting data. Either that or a transfer to emerge and or they died during the implementation study. We then created a data cleaning protocol and applied it to all the data. And then we had 4 of the clinicians on our research team analyze almost 600 resident encounters. And what they were analyzing it for was they had to answer 4 questions. Should there have been an alert? Should there have been a goals of care discussion? Was the reaction by the healthcare team in line with best practices? And if there was a transfer to the emerge, was it potentially avoidable? And we used this then to determine what proportion of cases would have benefited from having the alerts, and where we would have had a change in the management of these patients. In terms of the surveys, we initially designed the surveys for the staff as pre-post, and we wanted to assess a few domains. One is their adherence to practice recommendations, particularly for end-of-life care. What programs were already in place in the care community. How they perceive team decision-making, workload, and their interaction with physicians. And the reason we talked about interaction with physicians was that we often hear that particularly the healthcare aides or the personal support workers don't talk directly with the physicians, and so we wanted to see if the implementation of this communication tool might improve that. Our focus groups in Calgary were aimed at the frontline staff. They were recruited by our research assistants, and as well the long-term care home has a QI research lead at the site. And the main purpose of the focus groups was to ask them about the perception of the tools, as well as facilitators and barriers towards its use. And then the transcriptions of the audio recordings were thematically coded by two independent coders. So we're still in the process of analyzing some of our results. So I've chosen what I think are the most salient or most impactful. So these are as I mentioned, one of the long-term care homes in Toronto, we thankfully had some post surveys, and so this is pre-post for, and I don't think that this you can attribute causation or that it's statistically significant, but it's interesting to look at these trends. So we asked the staff how they felt their team's ability to proactively recognize and communicate early warning signs that would be important for flagging patients who need end-of-life care. As you can imagine, as you can remember, this is one of the objectives of our study, is to improve the ability to identify these things. And so what you see here is as it turns more gray, sorry, and it's cut off, I see that it's actually cut off the gray, but as it turns more gray is all of the time. You can see that from pre to post, there's less yellow, meaning that they never do it, and there's more gray, meaning that there's been some change in the time of the study where they're starting to identify dying trajectories, sentinel events, recurrent hospital transfers, and transition to end of life for high-risk residents as important flags that they need to look into. And while I don't think that the tools, because they didn't use them frequently enough, I'm not sure that the tools would be able, you could attribute it to this. We did do a lot of education, not just on how to use the tools, but on the importance of identifying these early warning signs, why the tool is important, and why these early warning signs are important. So not sure exactly whether this is attributed to the education or the tools or the presence of the research project and making them think about it more often. Same thing with communication. We asked them whether the team supports residents and families to make informed decisions consistent with beliefs, values, and preferences from admission to end of life. And what you see is that it's happening more of the time in the post surveys than in the pre-surveys. As well, team feels competent, comfortable, and supported when caring for a resident at end of life. Team uses effective communication to facilitate end of life discussions. And team feels comfortable communicating observations, assessments with each other, residents, and families. And so it's a positive trend, at least during the time of our study. At the end of our time in Toronto, we added a few questions to our survey. We wanted to know whether they thought that the alerts were helpful, and what you see here is that the majority did not find the alerts helpful. They weren't looking at it during their shift, didn't feel they could access the stop and watch alerts in a timely manner. And they didn't think that it was impacting changes to a resident's condition. Interestingly, in Calgary, where again, they didn't use the tools at all, we then went on and did a focus group because we wanted kind of richer information than what you can get from a survey. And what the participants there told us is that they were well aware of the tool, but they didn't think that there were opportunities to use it. They felt that they had been educated enough on the tool that that was not an issue. They thought that coming from the nurses wanted us to focus more on the healthcare aides, which we actually did. And they felt that they were satisfied with their status quo, that what's going on in their long-term care home right now in terms of identifying residents at risk and the way they communicate with each other was enough, and that it was working. And that's why they didn't feel that the tool was added benefit, even though initially when we asked them about it, they were quite excited. And in some of the preliminary surveys, they say that they're excited about it, but they haven't had a chance to use it yet. The other thing they talked about was workflow. So during the period of the study, they didn't have to double chart, but they did have to print out the electronic version and file it. But they interpreted this as double charting, and they were very busy, as you can remember, because they were also under construction and having outbreaks. They felt they were too busy to fill out this tool. And they also had some thoughts on the interface. So they felt that it was not easy to navigate, that the font was small, that it was not noticeable in point of care, and that they felt it was easy to forget to use it. Part of it is that especially the healthcare aides in Calgary, they have to check off, they have these buttons that turn red and you have to turn them green when you've finished an item or when you finished charting on something. And we did contemplate the idea of placing a button for the stop and watch alert that they would have to turn green, either that they didn't to check it off as unnecessary at this moment or that there's a change in condition. But we felt that within the time that we had, there was a risk that the nurses would potentially miss these alerts. And so we decided that it would require much more research into the interface and the culture of the long-term care homes. So interestingly, although the staff feel that they are really good at identifying when there's a change in condition, what we found when we did our chart review is this is, for example, the typical trajectory of a patient. They start out losing a little bit of weight, they're maybe not eating too much, then they have an episode where something happens. So in this case, this patient had an uncomfortable leg leaning to one side. Sorry, it says runny nose, not eating. At that point, they actually did think, oh, well, maybe there is a bit of a change in status. They had a goals of care discussion, but the substitute decision maker didn't want to change the goals of care and left them as going to acute care. And as you can see, there's a few other incidents where they're drowsy, they aspirate, they're lethargic, they're aspirating, they're not eating, and then all of a sudden they look pale, unresponsive, and they get transferred to the emerge and they die. And this is kind of a typical trajectory that we saw in our chart review, which begs the question, if the trajectory were made more obvious to the healthcare team and also more obvious to the substitute decision makers, it might be easier then to plan ahead and to have proactive goals of care discussions. As I mentioned in our chart review of about 117 cases, what we did after we answered the 4 questions was to look at whether the alerts were likely, had they occurred regularly or had they occurred as much as they should have, would they have changed management? Would they maybe have changed management, or would they not have impacted management at all? And what we found is that in Calgary, about 50%, so half, and in Toronto, 43%, for sure could have been impacted in terms of if the alerts had been present, it would have made the trajectory much more obvious and apparent. And then there were about a fifth of cases in both Calgary and Toronto where we thought that it could potentially have changed management. So when we started looking at the, initially when you see this, you start wondering, is there a problem with the tool? Is there a problem with the long-term care homes? And so we started sort of brainstorming in our team. And while the frontline staff are able to identify changes acutely, they still don't have an effective system for tracking these changes over time. And we think that there's still a gap where they still need some form of early identification or something that highlights the trajectory of the residents and that puts everybody on the same page. One of the things that became very clear from the frontline staff is that they would rather communicate in person, that they don't like filling out these forms. And so we think that needs to be at the forefront of whatever research comes next. One of the reasons we think that and this is something that we had looked at even before we started the study, is when you look at, so if you look at the the graph, here's my pointer if you can see it, the green graph, this is the trajectory of someone with dementia and frailty. And as you can see, when they're getting into the last part of their life, it's really hard to tell exactly when they're going to die because they're actually close to death a lot of the time, and then they kind of bounce back a little bit, and then they look worse, and then they bounce back, and then they look worse. And so having the alerts potentially could make it easier to predict this, because it's not as easy to predict in someone with dementia and frailty as it is in someone with cancer, where they have a clear drop-off, where they very clearly decline quickly, as well as someone with organ system failure, such as congestive heart failure or COPD, where you can tell that they're getting weaker and weaker, and they start to drop off, and you can see it very quickly. So we still think that it's necessary to have this tool, just that this particular tool didn't work in this setting. I think we need to take into account contextual factors and cultural factors that affect the use of the tool, such as competing priorities in our long-term care homes that I talked about. Time is a huge factor, as well as the culture of speaking in person. So that needs to be taken into account, and maybe the tool needs to be a lot shorter but facilitate communication. And the other thing is to look at the interface. So point-click care would need to re-examine the interface to integrate it better into Canadian long-term care home workflows. In terms of recommendations for long-term care leaders and clinicians, we agree that they have the clinical acumen, but that they do need some proactive way of identifying these patients so that they can review goals of care proactively, so they can change that care plan, and then they can also use that to manage their workforce, because at end of life, you probably need a little bit more individualized care, and for that, you need to be able to plan ahead. So our conclusion is alert, proceed with caution. We can't recommend the use of the tool in Canada at this moment, but we do think that there is the potential for further research with a gap that still needs to be filled. And that is the end of my presentation. So this is a quote from the Drummond report in 2012, where they said, an elderly person who is stuck in an acute care hospital bed is not getting the best care, which would be possible if he or she should instead be transferred to a long-term care facility or sent home with appropriate support. An efficient system would not let this happen either. And I think that was the purpose of our study. And actually the purpose of most of the work that I do. But I will leave it there and open it up to questions.
Great, thank you, Michelle. We've got a number of questions coming in, so I'll just start off with one around the involvement of family caregivers and whether they were involved in sort of the decision process or decision making in terms of you had indicated a flow chart of healthcare aides and whether a condition was urgent versus non-urgent. We have a question about whether family caregivers were involved in that decision process, or is that strictly something that the healthcare aides decide and move forward with?
Yeah, that's a great question. So what happens in their usual process in long-term care is that if the healthcare aide or the nurse notices change in status and they think that they're the ones who decide whether or not to call the family, and oftentimes the physician is not on site. So the nurse, the highest level nurse that's on the floor at the time, makes a decision about, do they need to be transferred, yes or no, and do I have time to call the family to get consent, essentially, and to make a plan. And what we found, it was kind of interesting when we were looking that for most of the patients, if they were transferred to the emerge, they would usually either send the patient and then call the family, or they would call the family, and sometimes they actually would say, we want to send the patient to the emerge, and the family would say, no, keep them here. And other times it was the opposite, where the family would be advocating even though they had a care plan in place. So that the involvement of the family caregiver is kind of at the discretion mostly of the nurse. It's not the healthcare aide that makes that decision. It's actually the nurse who decides, should I get the physician involved emergently, or should I send them to the emerge, or should I call the family first? It's really the nurse that makes that decision.
Okay, that's great. Related question is, and I'm not sure, but were family caregivers involved in any of the adaptation integration of eInteract with? Go on.
No, and the reason for that is that this is a tool that's meant for the frontline staff, and it's integrated into their workflow. So we didn't include the way we saw it in terms of the impact on families, and I didn't include the survey on families because I didn't think it was as impactful, but the tool itself was meant only for frontline staff. What we wanted to measure afterwards was the experience of the families for those that were and were not on resident care areas where they were using the tool. Because initially, what we were hoping to do in Toronto was actually to roll it out in different phases across the long-term care homes, and then use the ones that didn't have the tool as points of comparison. But we weren't able to do that because they ended up just taking the tool and kind of randomly using it in different floors, because some of the staff got really excited about the tool and actually used it on the floor where they weren't supposed to use it when they were on a different floor. So initially we were going to compare the experience of patients and families with and without the implementation of the tool. So that was how we were going to measure that.
Okay, great. Just related to the culture of long-term care facilities in Canada versus the US and other sort of factors and things that might incent the integration of the tool, we have a comment from a listener that remuneration of clinicians might be tied to the integration of the tool in the US. Is that something that you're aware of? And if you are, can you speak on that?
Yeah, so that's a really good point. So some of the U.S. long-term care homes, they have their funding, they're part of accountable care organizations where you lose funding if you have emerge transfers. And so they use the e-interact tools, not just the ones that we implemented, but they use the whole QI forum to report and to feed into the RAI. And so for them, being able to report that they've reduced ER transfers is really important because they otherwise get penalized. Whereas in Canada, we don't, as you know, have a culture of penalizing family docs or long-term care homes for sending people to the emerge. And I'm not sure that that's the right thing to do, but that's just the difference in culture between the two places. And so that was one of our hypotheses, was that there's not the same impetus in these long-term care homes in Canada to use the tool. I don't think they were as forceful with their frontline staff to use it because it's not tied to their funding. It was kind of like a nice to have for them.
Right, interesting. In terms of the paper tool, Interact versus e-Interact, are there LTCs in Canada that are using just the paper tool?
Yeah, there are. And actually, so the interesting thing is that within the same organization in Calgary that they have some long-term care and supported living, there was a QI project where they took the paper Interact tools, and one of my colleagues used it on paper in a supported living home. And in Calgary, in Alberta, the supported living structure is actually less organized than long-term care. It's less of a medical model because the physicians are sometimes just community physicians. They're not necessarily based at the site. And they had a lot more success with the paper tool. And the reason is because the paper tools are kind of quick, and especially the stop and watch is actually very fast to do. The issue isn't the stop and watch, it's the change in condition is actually quite long. But what they found is that the healthcare aides here loved using the stop and watch so that they could take the piece of paper to their superior and use it as to support themselves. But they didn't feel that it was overly burdensome in terms of the documentation. So they actually had some success. But e-Interact, I know there were a few homes who tried to use Interact while we were doing our study, and then Point Click Care decided that they didn't want to have them use it, so they shut that down. But the paper tools have been used, and they do have success.
Wow, well, that's interesting that the paper tool would be more easier to use and taken up more readily than the electronic version. Related to that question, or related to that topic, just curious, in terms of, you had mentioned that it was difficult for the healthcare aides and so forth to input the data. So did they have to go to the terminal or something and actually input the e-Interact data?
Yeah, so for the healthcare aides, they just have to click on, let me just go back to, I'll show you the, oh, I'm not on my presentation anymore, never mind. So for the healthcare aides, it's just the stop and watch tool. So they would just have to click on whichever of the things that they notice, like, you know, talking less than usual or needs more help. So for them, but yes, they had to go back to the terminal and do it. So that's another thing, that if you have your hands on a patient and you notice a change in condition and then you have to leave the patient to go back to the terminal, that's a problem. And the other thing that, not in this study, but in some other quality improvement work that we've done actually in these homes before we started this study. We know that the healthcare aides often do their charting at the end of the day. They're not supposed to, so they're actually supposed to be charting as they go along, but a lot of times they will just chart at the end of the day. And so this part of what we actually asked them to do is to not do the charting at the end of the day, because they're not supposed to anyway. So it's possible that that was a reason for not using the tool. And I guess if you had different technology, like if they were carrying around an iPhone or an iPad, which in the States they actually do have, they might be more likely to use it. The nurses, what they felt was that the tool, the changing condition tool, is quite long, and it is. We knew that, but we needed to test it. And I think the nurses also felt that they couldn't remember to check for alerts twice a day. That they're used to checking for non-urgent alerts, but that if something was urgent, they would much rather just have a healthcare aide come talk to them. And so, yeah. And so, especially when there was something urgent, what usually happened is that the PSW, and I'm saying PSW in Ontario because the Calgary ones didn't use it at all, but the PSWs would talk to the nurse, and maybe we'd get lucky and the nurse would fill out a change in condition tool, but they would forget to retroactively fill out the tool for us.
I see. Okay, great. Thank you. I have a number of questions related to the point-click care itself and sort of your work with them. Just a general question. Were they surprised at the results in terms of the lack of uptake of the tool?
Yes, I think they were quite surprised. I think that they probably thought when we started that this might be a walk in the park, because it's a tool that's already working so well in the US, so they didn't think it would be such a difference here. And yeah, I think they did.
Interesting. Okay, just looking at some questions here. I have a question about sort of your initial background slides. You had mentioned the falls being sort of an indicator of other sort of an overall condition of the patient. And the question was basically if you could speak to sort of reduction in medications and that being a possible factor in falls in long-term care facilities, and I'm sure you've got a lot to say on that.
Yeah, so it wasn't within the scope of this study to educate the staff on that. We were just trying to test this tool. But in my other roles, because I run essentially community senior services in Calgary, and in my other research, yes, and as a clinician, that you know, there's obviously certain medications like benzodiazepines and sedatives that can put you at risk of falls, or, you know, blood pressure medications. So for sure, the deprescribing of medications is a big deal. In Alberta, we've had a movement for deprescribing antipsychotics, and that I think is making a huge difference, not just in terms of, you know, not having people on antipsychotics, but those also put you at risk because they can be quite sedating. So in my other roles, I would say, yeah, that we didn't address that here. There were a couple of cases where we felt that there was something that we really needed to feed back from a clinician standpoint. So we did feed that back to the nursing homes. Like, for example, people who have diarrhea and then you put them on Imodium without actually figuring out if it's an infective diarrhea. But we didn't, in terms of the falls. I think also what I would say is that, you know, both in Alberta and in Ontario, long-term care homes have a lot of regulations around falls management. And so what we did see in the chart review is that there is a lot there in terms of falls, like that they are really trying. But we did see some sedative use, not as much actually, not that much, not excessive.
Okay. Just related to sort of a related topic, but still very important to this project, it's just the idea of, and you had mentioned this, of whether advanced care planning tools were used to support sort of care of the residents during your study, or whether that was integrated within the point-click care EHR system.
So each of the long-term care homes have their own palliative program. And so we didn't change that, but what we did look at was, and I didn't include this in the slides, but we did actually ask them, you know, do they know about the palliative performance scale, like some of the, the RAI and the palliative performance scale, and some of the, the chest score from the RAI, those kind of things that are tools that we use to estimate the sort of acuity and trajectory of residents. And we found that some of them didn't really even know what the PPS is. So there was some education around that, because one of the educators, actually both in Calgary and in Toronto, the educators that went with the research team were, well, in Toronto, Tracy Human, who is the palliative pain management consultant for Toronto, did the education. And then here we had someone named Kathy Rasmussen, who was also a palliative nurse educator. So we did talk a lot about those tools. They did get education on the importance of palliative care, but we didn't, it wasn't part of the scope of our study, if like in terms of, we didn't measure their use of it. Partly because we were having such a hard time getting them to just use the tool. But so yeah.
We appreciate the effort. Just a relate, sort of a general question, and it might be too early to ask this, but in terms of the chart reviews and sort of how those chart reviews sort of shed some light on whether eInteract may or may not have been helpful during some of those times. Just a general question in terms of whether those chart reviews and the findings were sort of fed back to the long-term care facility and the clinicians involved in terms of sort of just maybe educating them on the potential value of eInteract?
That's kind of in our plans now, because it took a really long time to go through the 600 lines of data and get consensus between the 4 clinicians. Like, we've just managed to finish that now, because we're all in different time zones as well. So we've just synthesized the data to that point where we can say actually 50% of your cases would have benefited from the alert. So we're just about to feed that back, actually. And it's we actually gave both the long-term care organizations the final report for the CFN that we just submitted, which has all that information in there.
Okay, that's great. That'll be really interesting to hear. I think you touched upon this question or this comment, but maybe you could sort of reiterate sort of how the tool was integrated, whether the nurse and or MD was sort of the primary sort of person or persons that were sort of integrating the tool, or whether there was a clinical champion or internal champion for the tool itself and so forth.
Do you mean integrating into the interface, like who would initiate an alert, or how it was
yeah, in deployed? Terms of yes, in terms of the use of the tool itself initially. Okay.
So healthcare aides and personal support workers have a program called Point of Care, which feeds into Point Click Care, which the nurses and the physicians use. And so the Stop and Watch tool is in Point of Care for the healthcare aides. And so when the healthcare aides are charting, they can click on the Stop and Watch tool, and then that generates an alert that shows up in the alert box and so they already have, all the long-term care homes have some alerts. For example, hasn't had a bowel movement in 3 days. So the nurses do already get some alerts, so it's not that different of a process, but right below it, we put the eInteract alerts. So there's 2 ways that you can kind of get into this. One is from Point of Care, the healthcare aide or the personal support worker can input a Stop and Watch tool, or the nurse herself or himself, if they notice a change in condition, then they just go straight and do a change in condition tool, which then feeds into an SBAR that they can print off and they can file in the physician's book. The physicians don't fill any of this out. The physicians are kind of the end user of the change in condition tool and the SBAR that results from it. And so the nurses would either, if it's non-urgent, would either file it in the physician's book, or they would call the physician and tell them what's going on.
Okay, great, thank you. We're coming up to the top of the hour, so I think we'll maybe close out the session now, and just want to remind our listeners that there will be a post-webinar survey coming up after the webinar closes, so please fill that out. The project contact information is on your screen there for Michelle and Greta, so please contact them directly if I haven't or Michelle hasn't addressed your questions. And again, a reminder that our next webinar will be on Wednesday, September 12th And so please register for that. With that, Michelle, do you have any final parting comments or thoughts before we close out the webinar?
Sure. So I think, as we went through this study, obviously when you're a researcher, you're not super happy to have a negative study. But what I find impactful about this is that, and particularly in my role for seniors, that this was actually a tool that a lot of people around the country were looking to use, because it's basically a switch that you can turn on in point-click care. And I think this kind of speaks to the importance of testing things out before and making sure that they're actually going to work in your context, before assuming that just because it worked in a different, in the United States, it's kind of similar, that it's going to work here. And so I think in some ways that this study helps us at least not to invest healthcare dollars into a tool that's not ready for prime time in Canada.
Right. Well, great. Well, thank you, Michelle, for that. And thank you for taking the time today to present your research findings. And thank you for everyone for being on the call today. With that, we'll close out the session. Thank you and bye.
Thank you.